So hello everybody and a very warm welcome to the Stoke Mandeville Plastic Surgery Educational Series. My name is James Chan and I'm a plastic surgeon at Stoke Mandeville Hospital. Thank you everybody for logging in, and it's wonderful to see you all. And I'm delighted to welcome all 800 or so of you from all over the world to our webinar today. So today our speaker really needs no introduction. He's a true giant of reconstructive plastic surgery and somebody who I'm honored and humbled to be able to call my mentor. And it's no exaggeration to say that there isn't a living plastic surgeon who has not been influenced directly or indirectly by Professor Wei. Professor Wei is the founder and leader of the unit that many call the Mecca of reconstructive microsurgery at the Chang-Gung Memorial Hospital in Taiwan. And I was privileged enough to spend a year there on fellowship, and it was for sure the best and most important decision in my career. And I would strongly encourage those of you who haven't been there to pay the unit a visit. Now, throughout his illustrious career, Professor Wei has transformed microsurgical practice through his innovative approach. He's made enormous contributions to the development of perforator flaps, as well as other groundbreaking concepts, techniques, and innovations which laid the foundation for modern microsurgery as we know it today, including the fibular osteoseptocutaneous flap for long bone and mandibular reconstruction, toe-to-hand transplantation techniques, and freestyle flaps to reconstruct other defects in the body. So unsurprisingly, therefore, he was recognized as one of the 20 most significant innovators in plastic surgery's 400 years of history by the American Society of Plastic Surgery, and also regarded among the top 3 most influential reconstructive surgeons in the 21st century. He has won numerous awards and honors, including the Bunke Lectureship and the Burdett Lectureship at Oxford University, and is ex-president of the World Society of Reconstructive Microsurgery. He's also the first surgeon to be appointed as academician by the most prestigious academic institute in his own country, the Academia Sinica in Taiwan. And this list goes on and on. But today we invite him to deliver his webinar at the Stoke Mandeville Plastic Surgery Series, not only because he's a shining beacon for all of us, but also because of his lifelong commitment to cultivate the next generation of surgeons and advance surgical care globally. He has trained some 150 fellows and has mentored well over 2,000 visiting surgeons from 85 countries, many of whom have returned to their respective countries to hold leadership positions. So he has truly, as Steve Jobs liked to put it, made a dent in the universe. Professor Wei, it is an honor to have you here today. I know many of the participants have been very much looking forward to this webinar. So just a brief announcement to the participants before we get started. As usual, we'd love to get as many of you involved as possible. So do use the chat function at the bottom of your screen to say hi and let us know where you're from. But if you have any questions or comments, and I'm sure there will be lots of them, please click on the Q&A function at the bottom right of your screens, and we will go through as many of these as we possibly can at the end. So, Professor Wei, thank you so much once again. The floor is yours.
Good afternoon to all my friends. It's indeed my great honor to be able to speak to you from this webinar. I'd like to thank James for making this arrangement, and I feel humbled when he introduced me. This afternoon, I'd like to share with you my experience of microsurgical reconstruction for the head and neck defect reconstruction. I think the goal of reconstruction of the head and neck surgical operation are multiple, but they mainly for protection of the vital structures that exposed during the surgery, and of course, to restore the function and the form are important. there are several reconstructive options for head and neck defect reconstruction. It can be divided into non-microsurgical and microsurgical. The non-microsurgical part, of course, including the local regional flap or even the pedicle flap. When we have both choice for the defect reconstruction, when are we going to use free flap transfer? That depends really on the expertise and personal and the personal preference. But in my mind, in general, basically when conventional techniques are difficult or impossible to achieve the goal, that is the time we should consider free tissue transfer. And sometimes when both conventional non-microsurgical technique and microsurgical technique are both able to provide reconstruction, at that time, if the tissue transfer can provide more definitive advantage over the conventional technique, then maybe it's also the time to consider using a free microsurgical transfer. In this presentation, I'd like to share with you how I use the free tissue transfer for head and neck reconstruction, including their use for the external face, for the facial contouring, for the intraoral lining reconstruction, tongue, esophagus, and the facial reexamination. I try to avoid this because in my department, we have Professor Chang, who specializes in facial reexamination. And therefore, I haven't done any facial reexamination in the past 30 years. So I'm not going to cover this. And I'd like to share with you how I reconstruct the mandible and maxilla. This is the number of free tissue transfer we have performed in the past almost 30, it's counting from 1984. Actually, I started microsurgical career in 1981. But the number between 1981 and the 1984, are not complete. So I decided to delete them. So this data showing the number of free tissue transfer for all kinds of reconstruction, including head and neck, upper lower extremity, and breast, as well as trunk. And they, at this time, to the end of last year, it's up to 23,000 cases. And here you can see almost 60% of the cases, that is 13,000 cases, were used for head and neck reconstruction. You see the number in 70 and 80 are not that many. But after middle of the, after 90s, then the number increased. And now we have about 500 to 600 every year for head and neck reconstruction. We have tried almost every kind of free flap that we know. But however, in the recent 20 years, my philosophy changed. I decided instead of doing so many kind of free flap and not able to mask all the flaps, it's better that we focus on a couple of flaps that they have the more advantages. So from this point of view, at this time, the top 10 free flap transfer done in my department. The top 3 is anterior side, the fibula, and gracilis, and followed by the radial flap. And as Jim just introduced, that we have many cases of toe transfer. So here you can see we have almost 1,000 cases of second toe. And then the others are like this list. Although we are able to do so many free flaps, I would like to suggest that for the people working in the unit that they don't have that many cases as we have here, I would recommend focus on the several workhorse free flap, especially for the head and neck. And for this, I like to suggest anterolateral side flap as the workhorse flap for soft tissue and coverage reconstruction in the head and neck area. Of course, in some of the cases that you need a little bit thinner flap or more pliable flap, that you may consider also the forearm flap. But for the bone reconstruction, I always like to suggest fibular osteocutaneous flap as the first choice. And of course, iliac flap or scapular flap sometimes can be used. But most of the time, I use fibular osteocutaneous flap. As I have mentioned, that the most favorite workhorse flap for soft tissue reconstruction is anterolateral side. This flap was developed or first discovered by Professor Song in China in 1984. At that time, he published, but it did not become popular, simply because at that time, there's still no concept of perforated flap. So all the skin flap depend on the septal vessel or the directed vessels. When you have the vessels coming from a muscle, then they consider this as a variation and abundant. But after middle 90s, the perforated flap concept evolved and people become familiar with that. So at this time, some of the anatomic variation become not a variation anymore. Like anterolateral side flap, the descending branch of the circumflex femoral artery is on the veli, located in the veli between the rectus femoris and vastus lateralis. And in the upper part of the thigh, it gives the branch to the skin through the septum between the vastus lateralis and rectus femoris. But in the middle and lower third, the skin vessels usually have an intramuscular course inside the vastus lateralis. And with the technique of perforated flap, once you identify the Doppler sound or with other image study method, you identify in the fascia area, the skin vessels. You regard its course is in between the septum or inside the muscle. You just follow its way to do dissection toward the proximal. In case you encounter this, then you do intramuscular dissection, and then you come and gain enough length for pedicle reach, and this time you are able to divide the pedicle. This is the way to harvest perforated flap. The advantage of anterolateral side flap, including a couple of very important things. One is that if you like to have thin flap, you can do the suprafascial dissection. And then you can further defecting some of those subcutaneous fat. But sometimes you need to include the fascia, either for increase the volume or for specific function, such as you want to reconstruct the tendon of fascia. Then you can do this inclusion of the fascia. This is the so-called fasciocutaneous flap. When you need a brachial flap, then you can include the muscle, either as a myocutaneous flap in this kind of manner, without need to dissect the skin vessels coming through the muscle. And sometimes, if you want to have more flexible, inset, you may like to harvest your flap like this, the so-called chimeric or combined type. Here is the pedicle, and have one branch to the skin and its distal continuation go into the vastus lateralis. You can also include part of the vastus lateralis for this kind of function. When you dissect your pedicle even more proximal, then you are able to include even the iliac bone for osteomyocutaneous flap. purpose. Here are several cases I'd like to share with you that we use anterior side to achieve the reconstruction goal. This gentleman present to us with Lombards disease, the congenital Lombards disease. And he has also the trismus because of the submucous fibrosis. So in this patient, we did some mucosa, some mucus fibrosis release. And then at the same time, we also use the same flap. This is the design. The entire anterior side flap, lateral side flap was elevated. And most of them were devascularized and leaving only a small skin island here. This is to replace the mucosa defect intraorally. And the rest of the tissue was used for augmentation of the soft tissue deficiency. So you can see this is the result, and the patient is also able to open his mouth. Here is another case of submucous fibrosis, bilateral. And so patient has trismus. So we use so-called one donor side two flap. Here we identify the Doppler sum. And we decide to use those that they have strong audible Doppler sum, yet they have the longer distance between those two flaps. And because of this kind of design, we are able to elevate two flaps from the same donor side. Here you can see this flap is used for the right side, and this flap still have adequate pedicle length is used for the left side. So after this reconstruction, the patient is able to open his mouth. And intraorally, here you may not be able to see it. It's become part of the buccal mucosa. Here is 3 cases of tongue defect. This is only hemiglossectomy defect without much involved of the floor of mouth. You can see the appearance. But when the defect involves not only the tongue, but also floor of the mouth, the reconstruction, they need more consideration. Like you need to fill the defect of this space, and you need to restore the resection. I mean the suspension of here. And then also you need to have transition between the tongue and the floor of the mouth. So to achieve the functional reconstruction, it's not the matter that which flap can do the things. You have to take all of this into consideration. Because of the time limitation, I'm not able to go over this detail of reconstruction. But here I'd like to share with you, sometimes you reconstruct the hemiglossectomy, and when it's associated with some floor of the mouth defect, you may, although you successfully in tissue transfer, but you may end up some unfavorable result, which include inadequate volume and include tethering, include slurred speech and difficult swallowing. And of course, sometimes they are fissura or sunken floor or mouth, or maybe an improper gutter. And those unfavorable results is because of lack of adequate reconstruction. How we can avoid this kind of unfavorable reconstruction for the individual items, here I have some suggestion. Like when inadequate volume is considered, then we always have to do oversized and even over volume flap. And to prevent from tethering, I think proper transition between the tongue and the floor of the mouth is very important. And then, of course, watertight closure can avoid fissura. And then adequate replacement of stop muscle or suspension of those floor of the mouth is the way to avoid sunken floor appearance. And in appropriate gutter can be avoided by a better and proper flap inset. So, I'm sorry, there's something. I'm sorry.
Yeah, no, we can see that fine. That's perfect.
Okay, so here is the case that we use anterior side, not only for the hemigrossectomy defect, but also at the same time, reconstruct the mouth, the floor of mouth. And here you can see how the patient is still able to move his tongue and a good speech. You know, come to the nearly total or total grossectomy, I think we have to pay even more attention. Here, I just simply show you one case. Here, this is the patient have the defect in the central mandible, and then also the total tongue reconstruction. So in this case, we use the fibular septal for the mandible reconstruction in the intraoral lining reconstruction. And then we use a combined anterior side, the flap, and associate with this vastus lateralis, and to serve as a functioning muscle. And here you can see this is the immediate appearance after reconstruction. And the speech, you just listen, is the speech that patient present to us about 1.5 years later. It's very intelligible and we can understand. And if you design the anterior side flap in a trapezoid shape design, then this can be used to reconstruct the pharyngoesophageal defect as here. Then you can see it's a tubing, and then to reconstruct the defect. And because of the volume, it's also helped to obliterate the dead space. So you see the postoperatively, the patient is able to drink well. The advantage of anterior side, I don't think I need to repeat, but I just like to remind you, it's not only provide so many advantage, it's also able to allow two teams work in most of cases. The excisional team is doing the excision in the head, in the proximal. And then while they start to do the resection, we are able to start our skin flap harvest at the same time. And because of many perforators, if we are able to finish the dissection of the flap earlier than the resection, then we can provide our trainee opportunity to do intramuscular dissection of some of the perforator that not affect the viability of the skin flap. And then to me, this is the practice for me and to develop the so-called freestyle free flap concept and the technique. Once you are able to have an audible Doppler sound, and then you do the proximal dissection, retrograde proximal dissection, ear regard is closed through the intramuscular septum or inside the muscle, you're able to elevate that as a small or moderate sized skin flap. So this is the so-called freestyle free flap. And so far we have performed about 8,000 cases of anterior side at Chang-Gung. Here you can see the number is about, every year is about 300 to 400 cases. And I'd like to talk briefly about the forearm flap. The forearm flap, although is not considered as the first workhorse flap, but occasionally it's still very useful. Like in this case, the small hemiglossectomy defect, we are able to use the forearm flap. And for the thin Barkham mucosa defect, we're also able to use the anterior side. As you can see here, this is the small skin branch from the source artery, the radial artery to that. And you can also include the nerve for sensory innervation. And here is the result. However, the donor side of the forearm flap sometimes has some problem, which include the sensory disturbance and failure of the skin graft take, and sometimes they have tendon adhesion or inadequate circulation related complication. And the major mechanism of such kind of complication is because of exposure of the patellar tendon or denuded tendon. And sometimes because of tendon of the musculocutaneous junction. And here is the conventional way of harvesting the forearm flap. You can see the tendon of the tendon. But if you are able to preserve the deep fascia and conjoined area of those two layers, just like this, here, if you are able to preserve this and do the so-called suprafascial dissection, then at the end of this dissection, there's no exposure of the tendon, and there's also no tendon of the tendon. And therefore, even a full skin graft is usually take quite nicely, like this case. Now, I'd like to proceed to do the segmental, mandibular, and the maxillary defect reconstruction using the vascular Spongrat. This is particularly useful when the defect, bone defect is massive, or when the defect is associated with intraoral lining, or even the external fascials. And sometimes in the irradiated area, or osteoradionecrosis, or previously failed bone graft, then the solution is to use vascular bone reconstruction. Although the vascular fibula has been explored and discovered from middle of 1970 because of the advantage of good length and good vascular pedicle, and also because of the good bone quality and controllability, then it's gradually become popular for use of mandible or maxillary reconstruction. However, before middle 80s, the reliability of the skin petals to the fibula still remained unknown. And because of that, at that time, if you have an associated defect intraorally or external face, this skin flap was not considered a reliable one. So limited its clinical use. This is a study that I had carried out in 1983. At that time, I have identified that the peroneal artery not only provide the circulation to the fibula, but here, as you can see, that through the muscle, it's also provide the vessels to the septum. This is the so-called posterior crural septum. It's located between the soleus muscle and the peroneus muscle. And here you can see two types of vessels. And this green one are those that they have not intramuscular course. But the red one, they have intramuscular course before it's reached the skin. And when you ligate this myocutaneous branch, and you inject the dye through the peroneal artery, then here is the staining area. This means that the skin petal here depend on the septal vessels of the peroneal artery, and it's centered at along the posterior margin of the fibula and centered at the middle third and lower third of the fibula. The intraoperatively, you can, once you see this kind of septal vessel, then you can confirm the reliability of the skin island that you are going to elevate together with the fibula. The fibula have received blood supply both from peroneal artery and the so-called intramedullary blood supply, and also receive some periosteal blood supply. So it's allowed osteotomy if we are able to maintain the circulation from the periosteal origin. This allows us to do multiple osteotomy, as you can see here. Because there's no muscle needed to be included to ensure the skin reliability, this gives the relationship of the bone and the skin a great flexibility. Here showing the fibular bone is parallel with the skin pedal. And here showing that the fibula is perpendicular to the skin pedal. And because of this kind of relationship, even when you perform double barrel fibula transfer, you're still able to include the skin pedal for simultaneous reconstruction of coverage defect. Here is the comparison between the different donor sites. In general, fibula is much superior in terms of the bone, its length, its quality, and its conservability, as well as the soft tissue component. The amount of skin available in fibula is almost like that of the ilium and the scapula. And the flexibility of contouring is because of multiple septocutaneous vessels. Here, I'd like to share with you some of the cases that is most suitable for reconstruction using the fibula. This gentleman, after oral cancer resection, resulted in composite mandibular defect. Here, the defect is from the in the body and to the ankle, and then associated with intraoral lining defect. So in this patient, we use a fibula osteoseptocutaneous for reconstruction, bone, of course, for the mandible, and some of the skin used for intraoral lining. But the rest of the skin was deepicalized and used to replace the soft tissue resection on the cheek area. And the patient can recover quite well, like this. And here is a huge amenoblastoma in a young lady. As a result of resection, the defect of the mandible is from ramus to the ramus, and very close to the subcondyle area. And then this fibula was used for reconstruction of the entire mandible, as well as of the intraoral lining defect here. And this is the appearance of the initial microsurgical reconstruction. After bone healing seen in the panoramic X-ray, then we proceed to do second stage osteointegration teeth implantation. And this is after 3 stages, abutment and the prosthesis. And you can see the good result of this patient. After accumulation of enough second stage osteointegration teeth to the mandible, we take one step further. We like to do primary osteointegration teeth implantation. This means that at the time of fibula for mandible reconstruction or maxillary reconstruction, we like to have osteointegration at the same time. because it's allow easily access to the bone for implant insertion. And also it's allow us to assess the alveolar relationship. And of course, it saves one or two surgical procedures and allow faster dental rehabilitation. This is the way we do our osteointegration teeth. We usually, after inset of the reconstruction plate and the fibula, we like to take down this contract and then do the osteointegration teeth on the side table. Here you can see our dental colleague was performing the dental implant. Then after this, we insert the contract, and then we use waxy screw to check the alignment with the upper jaw. And once the position is considered suitable, then we cover with cover screw. And then at this time, we proceed to do the microsurgical anastomosis. And here is the case that we adopt this primary osteointegration teeth method. You can see the defect, and here doing the osteointegration teeth on the side table. And in this patient, we have included a piece of skin. And this piece of skin was used for intraoral lining reconstruction as well as for soft tissue augmentation. You see here, this is the redundant part of the skin was de-epithelialized and used to provide additional back to here. And then here you see before the dental implant and then after dental prosthesis. And we, in those past 4 years, we even tried the so-called fibular joint a day, which means that the tumor resection, bone reconstruction, osteointegration teeth implantation, and the dental prosthesis, all the 4 procedures were done in the same operation. And this was first described by Levine of NYU in 2013, and there are not many reported. And up to last year, there are only 2 reported with a total of 7 cases, and 6 of them were for the mandible and 1 for the maxillary reconstruction. Instead of following their way, we developed our own so-called hybrid technique for joint a day. This means that we use minimal CAD/CAM to get the lithograph, and then also this kind of drill guide. This is a cheap drill guide. This is the only stuff that we need from the CAD/CAM concept. And then we use freehand technique for fibular osteotomy. And we depend on our visual decision of the dental implant location. And after that, we use digital oral scan, like in this case. After we insert the osteointegration teeth, then we use digital scan, and then this come up with this kind of digital scan. And then we have the dental processes, the custom-made dental processes that allow us to mill in them and then able to return to the patient and to complete the process in 1 hour time. And at that time, we were performing the microsurgical procedure. So we feel that if we want to do joint a day, we like to adopt the hybrid technique that we developed. And the advantage of such kind of approach is more cost-effective and time-effective. And then it still maintains the intraoperative flexibility because we always check to see if their vessel, the recipient vessel reach. And then after that, then we decide where to position our dental implant. And then after that, then we do dental processes. This is kind of intraoperative flexibility. So it's also allow us to use the included skin and the muscle in the fibula osteosyntrophic spread. And because of those advantages, especially the intraoperative flexibility, it may allow us to have a wider application of those techniques to even the pathology of malignancy and the osteoradial necrosis induced compound jaw defect for simultaneous soft tissue reconstruction. If you perform this hybrid technique, it includes the skin and the muscle. This intraoperative flexibility then allows us to have a wider application for compound or composite mandibular defect. Here we have a case performed in 2017. And then you can see intraoperatively, we have the dental implant. And then here, see we complete the processes. And then this is the follow-up about 2 years later. You can see we perform all those 4 procedures in one operation. As we know that fibula, the thickness is about 1 to 1.3 centimeter in average people. But the mandible almost double that of the thickness of the fibula. Therefore, when we use the fibula for reconstruction of the mandible, usually there's height discrepancy. And to overcome this height discrepancy, we have 3 methods. The first method is that you use additional reconstruction plate placed along the lower border of the native mandible. And then you place the fibula a little bit higher than, it's about 0.5 centimeter higher than the lower border of native mandible, and further fixed to the native mandible with mini plate, as you can see this one. And with this, then we are able to restore the height. And this is the panoramics of the complete dental implant. The method 2 is to use double barrel fibula. And like this patient, we then design our fibula, osteotomize our fibula in this manner. And this dental implant were inserted into the upper barrel. So you can see like this. And this C segment was removed to allow the curving of the D segment. This D segment is the one for use for low, as a low one here to restore the contour. And this is the arrangement. And at this time, in this case, also we have a nerve route to inferior alveolar nerve. And this is the result. When the operation being completed and found that the height of the neomandible is not enough, then we can perform transverse osteotomy and without injury the periosteum in the lingual site. And then after that, we can mount this destruction apparatus and allow vertical destruction. And then once you gain adequate height as you desire to have, then you can allow some time for consolidation. And then you gain the height that you want for insertion of the osteointegration teeth here. Here. And with this kind of technique, that we also able to reconstruct maxilla. And that this is the patient after maxillectomy resection, and then we're able to use the same technique for osteointegration teeth. As you can see here, it's one-stage reconstruction. And for the more complicated resection that involve multiple structure in the maxilla, then we like to suggest a two-stage reconstruction. In the first stage, you try to heal the wound and build the foundation for secondary osteointegration teeth. So this can be achieved with a soft tissue flap. And then after oncology procedure completed, then we are able to proceed to do the second stage maxillary reconstruction. So here showing a small piece of skin with the fibula for maxilla, and then osteointegration teeth at the same time. And here you can see this is the appearance. We also can use the joint day in a properly selected case, like this maxilla amenoblastoma. After resection, this was reconstructed with a fibula and then osteointegration at the same time. And then we have the sensor to allow us for intraoral scan. Yeah. And then we are able to perform joint day for the maxilla. So this is 1.5 years later. So the fibula osteoseptocutaneous flap is a workhorse for jaw reconstruction, not only because of reliable anatomy and good quality, and it's a straightforward dissection, versatile contouring and inset, and also the osteointegration teeth, but also because of the minimal donor size. See, here we have so far more than 2,500 cases of fibula mainly for mandible and maxillary reconstruction. Of course, some of them was also used for long bone reconstruction in the upper and lower extremities. The last I'd like to share with you is how to manage the extensive through oral mandibular defect. As this kind of patient, it's usually result from resection of T3 or T4 cancers. And for this kind of patient, one flap usually is not enough for an optimal functional and appearance. So therefore, we like to suggest two free flap. One osteoseptocutaneous flap for mandible and intraoral dining reconstruction. And the other one is for facial skin and soft tissue. Such as in this patient is a right floor or mouth cancer and involve the mandible and the external facial skin here. So you can see this is the defect created after resection. So in this patient, we use a fibula osteoseptocutaneous flap and even included a pedicle soleus muscle for mandible reconstruction and the floor mouth reconstruction here. And then another anterior side with the vastus lateralis for the external face reconstruction. So here you can see that all the defects were reconstructed with adequate, with like an adequate volume. And this patient follow up to 3 years. An advantage of two flap reconstruction is able to provide adequate tissue, which allow us to obliterate the dead space and to prevent the plate exposure. And of course, it's helped to prevent the scar contracture and adequate cheek back. And therefore, it allows us to achieve more functional and aesthetic result. And when we need to use two flaps, I always like to use the same site. Like if in this case, fibula is from the left lower leg, and the anterior side is from the left upper thigh. And while the operative surgeon is doing the tumor excision, we start to harvest the fibular osteosubcutaneous flap. By the time they finish the resection, we have already have the fibular osteosubcutaneous available for contouring, for inset, or for revascularization. And while we're doing those procedures, the second team from the reconstructive surgeon able to harvest this anterior side flap. By the time the first flap complete revascularization, the second flap is almost ready for transfer. So this can be from the same lower extremities, and there's no need for position change. This is a logistic advantage of combined fibular flap and anterior side flap from the same leg, not mentioning that both of them have a long vascular pedicle, which allow us even to reach the distant flap of the distant recipient vessel of the opposite side. Double flap with fibular osteosubcutaneous anastomosis provide optimal functional and aesthetic reconstruction. An overcorrection of the volume defect is always necessary, especially when post-operative radiation is needed. However, because from our previous study done about 6-7 years ago, that the because of the poor prognosis, 5-year survival rate, so now we do not use double flap for recurrent or second primary cancer. Head and neck cancer, although is notorious for recurrent second primary or tertiary primary, but it's a relatively localized disease with a relatively late metastasis. And the 5-year survival rate in most of the cases are rather, acceptable, that requiring the concern of the life quality. So because of this, it's a good indication for microsurgical reconstruction. So I'd like to conclude my presentation that microsurgical free flap reconstruction head and neck is able to help us to expand the range of tumor resection. And at this time, it has become the first choice in our reconstructive letters. And it has many advantages, especially when it's able to provide one-stage reconstruction, that able to provide better functional and aesthetic results, and with a relatively low and less severe complication in our hand. And I believe it's also in others' hand. And the rehabilitation is usually shorter, and patient can have less suffering from those microsurgical procedures than from other conventional local flap. I think with this, I'd like to conclude my presentation, and thank you very much for joining me in this webinar.
Great. Professor Wei, thank you so much. I think everyone will agree that that was a tour de force in microsurgical reconstruction of head and neck cancer. And it's always really inspiring to hear you talk about the incredible experience that you have at Chang-Gung, not just in numbers, which are astounding, but also the quality of the reconstructions. So thank you very much for sharing your wisdom, your experience, and your knowledge. Now, there are a huge number of questions, which I hope you don't mind answering. And I have recruited one of your other ex-fellows, Charles Lowe, who is a senior trainee in the East of England region, working in Cambridge and Chelmsford, to come and help me field some of these questions. Just to get us started though, I wondered whether I can ask you a question, really for people who are considering a career in reconstructive microsurgery. what's your advice to them, and what's your philosophy in how to become a competent reconstructive microsurgeon?
Probably my advice is that, instead of, following, all the donor side, and I think if able to stick to the concept of workhorse route, and that can help to master those surgical technique, easier. For the head and neck, and also for other, body part reconstruction.
Thanks, Prof. Wei. I just wonder whether I could ask you a question as well. I understand you've got a great interest in osteoradionecrosis, which is also part of head and neck, a sequelae, if you like, of head and neck reconstruction and cancer. Could you share a bit about your approach to managing osteoradionecrosis, which could possibly be other units?
Thank you very much. I think by definition, although people may like to grade, staging the osteoradionecrosis, but by definition, once it's named as osteoradionecrosis, it means that the bone has no reversible possibility of reverse its viability. This means that the bone are usually dead, and because of this, the hyperbaric O2 to me is not useful. And when you do the debridement, you have to prepare to do a major reconstruction, because the more you debride, usually the worse the situation. So when you try to surgically manage the osteoradionecrosis, most likely you need to do, almost like similar to that kind of cancer resection, the adequate resection, including not only the bone, but also the surrounding soft tissue that is not healthy. And then replace them with a fresh, light tissue, including, of course, the soft tissue of the bone. So this is my philosophy toward the osteoradionecrosis. Of course, you have to pay attention to see if there are any, hidden cancer in the osteoradionecrosis.
Thank you.
Great. There have been a number of questions regarding technique, and a number of questions have come in specifically asking about your algorithm and your decision-making process in achieving the alveolar height for the mandibular reconstruction and the dental implants. So you mentioned about using a single barrel osteocutaneous fibular flap, the double barrel, and the distraction osteogenesis. How do you make that decision?
It's when at this time, and it's because of my technique evolved over the time. But at this time, I always, if in the lateral, not in the central, I always like to have the, you have to restore the the continuity of the low border of the native mandible. This can be achieved with a reconstruction plate. And if you aim at, osteodecreasing teeth, then you need to press your fibular bone a little bit higher. So that it's, when the osteodecreasing teeth is complete, it can oppose the upper jaw. So the fibula is usually pressed about 0.5 centimeter higher than the low border of the native mandible, and then fixed with the mini plate. So if at this time, I have one reconstruction plate and then mini plate for fixation of the osteotomized fibula to the mandible. This is my current, practice.
Right. So, Charles. Okay, I think.
Prof, I'd like to ask some questions here. They were asking about the laterality of your fibular flap, and does that matter for which side? I understand when I was with you that this did not really matter which side you use for the fibula to reconstruct which side.
Yeah, thank you very much. I think this is a very important question. Many people are confused by the laterality. And it's very difficult for someone who have no experience or have very little experience to figure out how to the laterality, especially sometimes when you have a difficult neck or when the original design, vessels, recipient vessels become not useful, not usable, or not available. Then during the intraoperative, intraoperative, you need to change, right? So this can be encouraged. So make the things easier. I like always to have the fibula from the left side, unless the left side is not usable or not available. Always use the left side. And then depend on how you place, how you insert the fibula. Like for example, if you use the proximal to distal from lateral to the middle, then the vessels have a nice curve toward the ipsilateral neck. But if you use the proximal to the anterior, the proximal fibula to the anterior, then it's better that you have your vascular pedicle, to go to the opposite side, so that you can have a smooth, pass of the pedicle vessels. Do not make a twist or a big curve for the fibula. So this allows intraoperative, change. That if you believe the laterality is important, then intraoperative encounter, the problem with your original plan, the recipient vessel, then you are in trouble. You are trapped, especially when you need to reconstruct the soft tissue at the same time. Then you have no way that you are able to do intraoperative, change. So please follow my way. The left side, always use left side. And you can design your skin island either more anterior or more posterior. Of course, you cannot miss the posterior crural septum, the septal vessels. And then intraoperative, they depend on where is the suitable recipient vessel on the ipsilateral or contralateral. Then you can insert your flap, properly and allow the vessel to reach the recipient vessel without kinking.
Thank you.
And whilst we're still on the topic of the subcutaneous fibular flap, there's now a lot of interest in the CAD/CAM movement. Can you share with us your thoughts on that, the pros and cons?
Yes, actually, I have no objection to any new technology. But if you think about the socioeconomic and the healthcare system in your country, and if you feel that $6,000, US dollar is affordable, go ahead to do it. Go ahead to do it. But if you feel this is in comparison with the other fee schedule, this is unreasonable, then you have to avoid doing that. And especially if you addict to that, then you have no intraoperative flexibility. I really like to see someone who believes that and then able to come up with the statistic, how many of them perform this CAD/CAM and intraoperative, they have to abandon the planning CAD/CAM. So although, but I believe the CAD/CAM is able to help you to have the best contour. That this is true, but that is not that difficult to achieve. If you have, as I suggest, minimal CAD/CAM, you have a lithogram, that may take you only less than 1,000, less than 1,000. Maybe in Taiwan, it's cost about $500 to $600 US. And with that lithogram, then you can bend easily. They are, they are, I think that they are
malleable.
They are plate that you can do only minimum bending, then you can get this kind of, the contour. And then also I notice even the contour is very good. Sometimes because of the soft tissue issue, the appearance still not that good. And sometimes although you have a little bit imperfection in the contouring, but you end up, you have very good result. So in my opinion, I don't mind to use CAD/CAM, but I would suggest before you use the CAD/CAM, you have to master freehand technique. This is my suggestion.
Right. Thank you. Charles.
I see a few questions here on blood thinning and antibiotic regime protocol. Prof, do you use aspirin, heparin routinely?
No, we don't.
Thank you.
All right. So there's still lots of interest in the jaw in a day, and people are asking how long does it extend your surgery?
Not much, actually. As I mentioned, that it's almost like a primary osteodegradation teeth. Okay, and then at the time, when you complete the primary osteodegradation teeth, let me put it this way, because we have very, very good experience of primary osteodegradation teeth, and what the jaw in a day added is that you have the processes met at that time, at the same day, right? Actually, when we before we do the microanastomosis, because we always insert the flap first. And after that, then we proceed to do microsurgical anastomosis. And when we start to do microsurgical anastomosis, before do that, then we have a, the intraoral scan. And then they have the prosthetic, how do you call that? A piece of dental prosthesis, and they can, based on this intraoral scan, they can mirror. We have an in-house mirroring this dental prosthesis. So by the time we finish microanastomosis, it's become available. It's usually about 45 minutes.
Right. And in patients who are going to need adjuvant radiotherapy, do you still go ahead and do the primary osseointegration dental prosthesis or not?
Most of the cases I don't, unless the patient requires, because in our healthcare system, the company doesn't cover the dental prosthesis.
Right.
But we do have several cases that we perform this before radiation, and it seems to us so far, but it's because of limited number. So far, there's no complication. I think I have about 5 or 6 cases only.
Right. Charles.
Prof, there was a question earlier on. They asked about recipient vessels and your choice, your go-to choice if you don't have to open up the neck, say for your submucous fibrosis cases. I understand your preference would be facial, the facial artery and vein.
Yes. Either facial artery or superior thyroid artery are most commonly used.
Great. For the going back to the fibula, when performing an osteotomy, what's the minimum length of segment you can do before you worry about the blood supply?
Yes, I'm very concerned about the blood supply. You know, sometimes we have to compromise a little bit, and you know, people, especially in the publication, they emphasize too much about, you know, the contouring of the bone. And actually, I'm very keen to know, you know, how many complications, how many including non-union, you know, those complications of bone non-viable, because no one really, you know, have reported this, and they all report the good cases. But I believe once you make your osteotomy too short, especially if you want to do osteodecreasing teeth, or you have the, you know, we know that the blood supply to the fibula is double of blood supply. One is endosteal blood supply, that is the main one, and the other, it does weigh about 2/3, and the periosteal blood supply is only 1/3. And if you do osteotomy, more than one osteotomy, then you may you already divide the endosteal blood supply. So it depends only on the periosteal blood supply. And at this time, if you have a reconstruction plate or mini plate or even osteodecreasing teeth, then those surgical procedures further reduce the circulation to the transplanted fibula. So for the safety reason, you know, I like to suggest a very minimal stripping of the periosteum, and even no stripping when you drill, you know, hole, and then do not make it small. But in my practice, when it's become smaller than 3.5 or 3, then I become very nervous.
I think we've got time for a couple more questions. Charles, have you got one?
Prof, there's a question here on, interestingly, of course, something that you encounter quite often, because there are quite a lot, these patients in Taiwan are surviving quite long in terms of the head and neck cancers. You see them come back. When I was there, at least patients were going for 3, 4, 5 flaps. There's a question here on vessel depleted necks and how you tackle the lack of a recipient site, recipient vessel, for example.
You know, actually, if you know, review the anatomy, then we know that there are several, you know, vessels commonly available. Of course, the most commonly one is facial artery, superior thyroid artery, and more proximal is the lingual artery. And then in the temporal area, superior temporal artery, but in the neck, long neck, then you have transverse cervical artery. So that means on one side you have 5. You have 5. On the other side, you have another 5. You have another 5. And of course, some of them you may not reach. But if you are able to adopt some strategy, you know, you can cheat on the flap, like you move more toward that side so that you can reduce the need of the pedicle. Then I think even we commonly perform the cases for the second time, the third time, the fourth time. And we really use those that, you know, published in the journal, such as those that coming from the cephalic vein, you know, hinge ups, or, you know, do the other, and even very few cases that we need a vein graft. So this depends very much on how you plan and how you choose the flap. If you choose the flap that have a longer pedicle, you know, like anterior side, often you have long pedicle, and even the fibula. If the fibula you need, the bone is not that long, you can use the more distal bone, and then proximal you can gain some length. Or if you want to, you know, reach the vessel here and it cannot reach, and then the flap can, you know, defects here, then you can press your skin flap more, you know, toward this I mean, toward the recipient vessel. By doing this kind of cheating, you're able to, reach. We are not afraid of using vein graft, but if you often use vein graft, that means your planning, surgical planning must be inadequate.
Thank you. Yeah.
And a final question from Susanna Jung. Whenever you use a vastus lateralis muscle for dynamic reconstruction in total or subtotal tongue, how do you design the inset of this muscle?
Actually, we know that muscle only can achieve one function. So this should be, aiming at I have no time to cover this, as I mentioned. In this case, we have made a very good progress, means that we get good result, but it's not constantly good result in those patients. We have to know, as I shown that the tongue cross section, that we have to fill the dead space here, and then you have to create the transposition between the tongue and the floor of the mouth. And then if you have include the vastus lateralis muscle, it can allow you to replace one function. The stylogrosso, that is the muscle. You replace. You try to replace.
Great. Thank you so much. Well, that's that concludes our Q&A session. Thank you once again so much on behalf of the 800 or so people who have registered to listen to your talk, Professor Wei. We're very grateful and very enlightened.